All right, pheochromocytoma. So this is there'll be last two topics for um adrenal problems. Okay, so we've got pheochromocytoma. This is a tumor. Now this is growing on the adrenal medulla. So if you recall last week, we talked about the adrenal cortex, yeah, which was producing the salt, sugar, and sex hormones in the female, and then the only salt and sugar hormones in the male. So this one is in the medulla. So what hormones are produced by the adrenal medulla? They are the catecholamines, your epinephrine and norepinephrine. So if there's a tumor growing there, what do you think will happen to this patient? Okay, there will be high levels of epinephrine and norepinephrine. So think about a fight or flight condition, which is constant. The patient is constantly in a fight or flight situation. So what is the heart rate? Very high. What is the blood pressure? Very high. This is epinephrine. This is always constantly fight or flight. This constant production of epinephrine and norepinephrine. And this is a tumor. The tumor here is quite big. So since the adrenal glands are growing on top of each kidney, so supposed to be the kidneys are located in the retroperitoneum, correct? The back in your flank area. Now, since the tumors are so big, they're going to be palpable on your abdomen over the left and right side of your abdomen, whichever adrenal gland they're growing. They're growing on the one or both adrenal glands. But the patient will have extremely high blood pressure, extremely high heart rate. Patient's always sweating, person's always nervous, they'll have tremors. Okay. The As stated here, the tumor grows at any age but peaks around 40 and 50 years of age. Stations, as already mentioned, the patient will have severe hypertension. So the patient here, usually hypertension doesn't have symptoms, right? But here, because the blood pressure is so high, the patient is symptomatic. So the high blood pressure here causes symptoms. So they'll have headache, diaphoresis, and palpitations. What could happen if you have really high blood pressures like this? Can you have a stroke?
Yes.
Can you have a heart attack?
Yeah.
Okay, so those are complications of the condition of the tumor. There's also hyperglycemia in these patients. Okay. Now, one thing you never do is palpate the tumor deeply. You can touch the tumor, you can touch it over the abdomen, but never palpate it. Because if you palpate it, it causes a sudden rush of catecholamines, and the patient may have a stroke right there and die instantly. Here are the other manifestations when the patient has uh, attacks. The patient has, again, exaggerated symptoms of the hypertension, the tachycardia. Look at the blood pressure. They can exceed 250 over 150. So these are, again, life-threatening levels of hypertension. Patient, again, could die from a stroke and definitely AKI as well. Here are the 5 H's. If the patient has all 5 H's, then this will help diagnose the condition, the pheochromocytoma. Let's go now to the management. So since it's caused by a tumor, what do you think the management is? It's caused by a tumor. So what do we do with it with the tumor? We remove it. Okay, so surgery will be indicated. However, can we just take it out when the patient's condition it has been like this for a long period of time? No. So the patient, until they're ready for surgery, will have to be placed on bed rest and then placed on several antihypertensive medications, beta blockers. All right. So here are our drug therapy. So before surgery, the patient has to manage blood pressure. We cannot take the patient. Is it safe to take the patient to the OR with a blood pressure of 250 over 150? No. So we have to stabilize the blood pressure first. The blood pressure must be within normal before we can take the patient to surgery. So patients going to be on several, as I mentioned, several antihypertensive medications. So we got alpha blockers. We're also going to give beta blockers. We're going to give calcium channel blockers. Okay, so a cocktail of antihypertensive medications. And then finally, surgery. And since we're removing the tumor and the adrenal glands here, will the pre and post-op care be any different from adrenalectomy we talked about in the last week for Cushing syndrome? Will the pre and post-op care be different? Exactly the same. So let's review last week. For adrenalectomy, if the patient is going to, so let's say, I forgot to mention this last week also. If the patient had, let's say, Cushing's disease, that means the salt and sugar hormones have been high constantly, correct? Right. And then when we perform surgically and then we remove the adrenal gland and the tumor, what happens to the patient's salt and sugar hormone levels? We removed the adrenal gland. So what will happen? Did it go down slowly or did it go down abruptly? So is that safe? No. So what do you think is the preparation before adrenalectomy? What will be given to the patient pre-op? So, Miss Aficito, so you asked me this last week. So how do we manage patients with Addison's disease? We give them steroids, right? Yeah, so the steroid is hydrocortisone, right? Or fludrocortisone. Fludrocortisone is PO. The benefit of fludrocortisone at high doses is it doesn't just act as a glucocorticoid, but also as a mineralocorticoid, meaning it will cover the function of both gluco, meaning cortisol, as well as aldosterone. Okay, that's the beauty of fludrocortisone. Anyway, so go back here. So let's focus on adrenalectomy. If we are removing both adrenal glands, now this will apply also for Cushing syndrome, okay? So if we remove the adrenal glands at the same time, what happens again to the patient's hormone levels? Both the salt and sugar hormones, it will drop. Did it drop slowly or did it drop abruptly? It dropped abruptly because you took out the gland. You removed it. You cut off blood supply to it and then you took it off. So therefore, what did we say again with what happens if there is sudden cessation of long-term corticosteroid therapy? What is the result? Adrenal crisis, correct? Addisonian crisis. Will this be any different? This will what's going to happen. So therefore, to prevent adrenal crisis, what will we give the patient before, during, and after surgery? Steroids. So we will begin infusing IV steroids before surgery. It will continue during surgery. And then what do you think will happen after surgery? Because now the patient doesn't have adrenal glands anymore. So what do we call the patient now? What does the patient have? Addison's disease, right? Or adrenal insufficiency. Any questions? All right. Now, since we're talking about steroids here, what are the effects of steroids again? So remember Cushing syndrome and Cushing's disease. So if you have high levels of aldosterone and cortisol, what happens to you? Let's begin with your blood pressure. Blood pressure will be high, blood volume will be high, sodium levels will be high. We already said sugars will be high, correct? And what happens to my immune system? Jamie, what happens to my immune system? Because I'm taking steroids. I will become immunosuppressed. Okay. So these are now the effects, right? Once I start steroids. So when did I start steroids? If I undergo adrenalectomy? Before, during, and after surgery. How long after surgery? Couple weeks?
Right after.
No, for how long? I mean, for how long? Lifelong, because I don't have adrenal glands anymore. So, since I will have decreased immunity, is that correct? I just had surgery. So what will happen to my surgical incision? I just underwent surgery and I'm taking steroids. I started taking it before surgery, during the surgical procedure, and then forever after surgery. Will there be a good healing? Okay, so your priority is promote healing. So yes, we can't stop the steroids, correct? So we'll have to give the patient high protein, high calorie diet to promote healing, and then vitamins and minerals as well. Are we clear? All right. Now, what if I only lost one adrenal gland? The pheochromocytoma only grew on one adrenal gland. Will I have Addison's? I lost one adrenal gland. Okay, I will probably require steroids for a short term only, until my remaining adrenal gland compensates for the lost one. Are we clear? Any questions about pheochromocytoma? This is basically a tumor, a catecholamine producing tumor. Surgery is the permanent treatment. However, as a result of surgery, what will I develop? Addison's disease, especially if I lose both adrenal glands. But again, if the pheochromocytoma only grew in one, will I have Addison's? No. Please read the rest. The hypertensive crisis here is not any different from the hypertensive crisis you learned in MedSurg 1. So let's briefly review. So what is your first action if there is a hypertensive crisis? Let's say my blood pressure is 250 over 150. What is your first action? This was not any different from preeclampsia. You talked about preeclampsia before, correct? All right, so what was your first action once the patient was in preeclampsia? Preeclampsia also had severe hypertension, correct? What was the first action? Go ahead. What was the action? No. Medication wasn't the first action. It was the second, maybe the third. What was the first action? What position? Sit the patient up. Okay, so place the patient in a sitting position. Okay, so that action will begin to drop the blood pressure. That's your first action. And after that, of course, it's either give antihypertensives or I'm not sure if it's give antihypertensives or if the second action was assess neurological status. Because what can happen with the blood pressure that high? A stroke. Okay, so it'll be position the patient, sitting position, assess neurological symptoms, and then administer antihypertensives. What route? IV. What do we never do again to the tumor? Never palpate. All right, that's it. Let's go now to the last adrenal problem. primary aldosteronism. What's the function of aldosterone again? This is the what hormone? The salt hormone, right? So what does it do? It commands the kidneys to do what? Reabsorb sodium and water. When is this usually released? Yeah, when is the renin, angiotensin, aldosterone system stimulated again? Whenever blood pressure drops. What else? Blood volume drops, oxygen levels drop, sodium levels drop, or glucose levels drop. Very good. So this is automatic, yeah? So whenever, let's say, if I hold my breath, what will happen to my oxygen levels? It will drop. Will it trigger aldosterone release? Yes, okay? So as simple as that. So if I have a condition wherein I have so much aldosterone, by the way, there's another condition which is called hyperaldosteronism. This one though is primary aldosteronism. Okay, so this condition is also called Conn syndrome. Okay, so it's usually caused by a tumor again. However, unlike pheochromocytoma, wherein the tumor was in the medulla, this one is in the cortex. However, this tumor, unlike Cushing's, does not produce or does not release cortisol. Okay, this is only going to release aldosterone. Okay, only aldosterone. So describe the patient's manifestations. So since the patient has high levels of aldosterone, so what will be the patient's sodium levels? Very high. What happens to the patient's blood volume? Very high. Blood pressure? Very high. Potassium? Low. Very good. So here, there's hypokalemia. However, as stated here, not all patients will have hypokalemia. But theoretically speaking, yes, you would assume patient has hypokalemia in this condition. So manifestations, of course, will be someone with fluid overload, with high sodium levels. So they'll be very thirsty. They'll have high blood pressure. They'll have edema because this is salt and water retention. So there will be edema here, peripheral edema. Management, removal of the tumor, same as pheochromocytoma. Until then, again, if the patient is still very hypertensive, can we subject them to surgery in that state? Again, we manage the blood pressure first, get it to as low levels as possible. So until then, the patient will be on another cocktail of antihypertensives, including diuretics, especially diuretics. And then once the patient's blood pressure is stabilized, patient is taken to surgery, and then we remove the tumor. If the patient is not a candidate for surgery, then they'll be on antihypertensives forever. If for whatever reason they cannot have adrenalectomy, then they'll be on antihypertensives forever. And as already mentioned, is the pre and post-op care different here from Cushing's disease and also in pheochromocytoma? The same. So same exact pre and post-op care. So therefore, if the patient loses, let's say the tumor is on both adrenal glands, what will the patient have after surgery? Addison's disease. If only one? No, temporary hormone replacement up to a year, maybe a little bit more. Any questions on the adrenal problems? Okay, very good, children.